Welcome, and thank you for joining the Fielding School of Public Health's Continuing the Conversation webinar. Culture influences our healthcare decisions, access, and utilization of care. Dr. Marjorie Kagawa-Singer, an oncology nurse by training and a professor of community health sciences at the Fielding School in the Asian American Studies Department, is developing guidelines with national culture and health experts for a more scientifically grounded use of culture in research. This framework will guide researchers and reviewers to define, measure, and apply the concept of culture for basic and intervention research. In this webinar, Dr. Kagawa-Singer will describe her 18-month project and how the concept of culture will help reduce disparities in health outcomes, especially for people of color. We want this to be a dialogue, so we will allow plenty of time for questions. If you have a question, simply type it in the field at the bottom of the chat window in the bottom left-hand corner of your screen. Let's get started. Dr. Kagawa-Singer.
Thank you very much, Ashley. I'm excited to present this project. It is in process, as it says, a work in progress. We hope to have the final report completed in March or by the 1st of April. So what I'd like to do is walk you through what we have at this point and talk about the issues of actually including culture more effectively in healthcare research. The first is that culture is just fundamental to human existence. Clifford Geertz wrote in 1973, "There is no such thing as human nature independent from culture." And yet it's so poorly used in healthcare that it's a bit, one, surprising, and as a medical anthropologist also a bit frustrating. Culture is a way, as Bruner notes, a way of life and thought that we construct, negotiate, institutionalize, and finally end up calling reality. So what we see and how we see the world and how we make sense of it is culturally dependent. Oppenheimer then wrote in AJPH in 2001 that despite its central role in explaining behavior, no other variable used in health research is so poorly defined and untested as culture. So to take such a fundamental concept and assume that we're using it correctly is problematic when it's used in such an unstandardized manner. So what are we missing and how do we find it? The first is to develop a well-grounded concept of culture based from the existing literature, primarily in the social sciences. To then measure the concept to accurately operationalize the concepts of focus for health, and then scientifically test the hypotheses of the effect of culture on health. So the goals of our project, which has been funded by the OBSSR at the NIH, is to scientifically define culture for use in health research and to propose a set of recommendations to guide both researchers, reviewers, and funders in the measurement and application of culture. To give you an overview and a preface to how we're defining culture and addressing those objectives is to first talk about how it's currently used and what some of the shortfalls are in that approach. The first, so I'll be listing 10 common problems and pitfalls. First is an incomplete conceptualization of culture. Even though hundreds of definitions exist, the way it's actually incorporated into many of our health research studies is very truncated. And we'll go into that in more depth in just a moment. The lack of incorporation of the dynamic nature of culture, using false assumptions of universality of the dominant culture's construction of reality and selfhood. Much of our use of culture is based in our health behavior theories, which come from psychology, and the concepts of individuality, which are very important here in the United States, don't translate well across various cultural groups, either nationally or internationally. And we'll present, and the present focus on diverse populations without the historical and political context of the group and the role of culture the culture of science in the United States. We use measures that are nominal and dichotomous to operationalize culture. We use unidimensional definitions that don't capture the complex system nature that is actually culture. Very often we see in research a conflation of race and/or ethnicity and/or ancestry as proxy measures instead. I'm going to pause here and go through some definitions that indicate how different each of these concepts are, and to conflate them just makes invisible the major issues within each one. First, I think it's clear now that race in and of itself is a myth. There is no scientific basis, genetic basis for this. There's more within group genetic variation than there are between groups. And you cannot tell a person by their skin color what, quote, race they are or population group. The other is ethnicity, which is one sense of identity as a member of a cultural group, and notably here within a power structure of a multicultural society. And individuals are identified so by others for membership, and it's based on social, historical, and political contexts. Ancestry is defined as a person's ethnic origin, heritage, or roots, which may reflect their place of birth of either themselves, their parents, or ancestors, or ethnic identities that have evolved within the United States, and this definition comes from the U.S. Census Bureau. Now, where race does have a major impact is through racism, which is the assertion of power, ego fulfillment, and status at the expense of others based upon skin color or other phenotypic features. So knowing then that each of those are different, then the focus goes back to culture for this presentation. And the seventh problem and pitfall is the assumed homogeneity within any population group, and this is often reflected in our sample selection and the lack of stratification in sampling, because it's unclear then, number 8, what the parameters are of the population of focus for sample selection. And very often what we're actually looking for are subpopulations, but that's not clear in the way that the sampling strategy was either implemented or at least described. 9 is the focus on the individual culture bearer rather than the social and environmental context for the group. And all of these, 1 through 9, impact the lack of progress in eliminating health disparities. Now, on the issue of the lack of health disparities, Leonard Syme wrote in 2008 that we've spent 40 years funding studies to eliminate health disparities, and yet we've made no progress. And it's the sort of the consensus of our expert panel members, who made up of 30 individuals from across the country who represent 8 different professional disciplinary backgrounds, that may be one of the lack of attention to cultural variations may be a major reason that we've had no progress in this very needed arena. Whoops. So I'll begin by then defining culture. And I'll differentiate between what culture is and what culture does. and then how the culture of science and scientists trained within this culture, the dominant U.S. culture, too often see their own cultural blinders in studying and practicing in cultures different than their own. So culture is a shared framework or prism that its members use to see the world and informs their conscious and, importantly, unconscious actions to live life, solve problems, and inform decision-making. It also is created and modified within a multidimensional, multi-level, ecologic living system. It's a shared way of being and interacting and is socially and legally integrated into the structure of a society's institutions. The 5 fundamental characteristics of culture, then, is that it is learned through the course of living their lives with other people through the processes of language acquisition and socialization in order to function acceptably as a member of that group. It's dynamic, adapting, and evolving. As any system, there are multiple feedback loops across layers as well as within. And its members are ever-changing as they respond to changing circumstances and groups, including multiple and fluid memberships in other groups. It's an adaptive mechanism to maintain for its members a sense of safety and security, a sense of integrity, and a sense of belonging. What makes the measurement of culture very challenging is that it exists implicitly rather than explicitly in the minds of its members of social groups. If you think for yourself, what is normal, natural? That's culture, and it's usually invisible because it's just the way things, quote, are. The members of the culture have multiple cultural identities that are often time and context specific, such as gender roles. You're a mother, you're a son, you're a supervisor, you're a pastor. Each one requires different beliefs, prescriptions for behavior, roles, responsibilities, and they will shift according to the context. They're differentially distributed throughout the members of any cultural group. So the idea of homogeneity within any population group is a falsehood. What culture does, then, with this background is, as a multi-level, multi-dimensional framework, it defines and constructs the world around us. It enables us to interpret the world and derive meaning in and for life. Every culture also provides the social structure that defines and coordinates these numerous roles of each of its members in relation to the group and provides rules of social interaction and a distribution of power. The built environment, including our institutions and healthcare systems, also express the cultural framework of its members, which is why members from other cultural groups may not be able to access or utilize our healthcare system in the way it's intended. We use 2 conceptual models for the project. The first is McElroy and Townsend's ecologic model of culture, which will more pictorially indicate the multi-level, multi-dimensional elements that I've just spoken about, and Myers' revised capacity and cumulative vulnerability models for minority health. In this conceptual model, you'll see there's the biotic, abiotic, cultural frameworks that impact the human population all the way down to the DNA. And this is where the exciting area of epigenetics is beginning to indicate how individuals, through their behavior and their environment, are impacted on a cellular level and impact health outcomes. So the biotic, abiotic, and cultural systems are very direct pathways to health outcomes. The conceptual model that was developed by Myers in 2009, he calls it his spaghetti model, to show how complex the issues of race, ethnicity, and culture and impact health status through multiple pathways. And all of these exist simultaneously, and the various disciplines will focus on many, if not all, of these different pathways, although often not simultaneously. What has been missing in this process is an integrative framework. And this is where we've come up with the focus at this point in time is primarily on individual and cultural groups, sort of acontextually. We haven't taken into consideration the researcher's culture and what the framework of the theories are based in, which is another culture. In addition, researchers and the group cultures exist within the larger societal culture. And this becomes part of that McElroy and Townsend ecologic model, is understanding the influence of these various perspectives and how they impact health behaviors. And they will be geographically different, as well as the outcome in and of itself for particular populations. The research nexus requires that we take all of these into consideration in developing any study. The three intersecting subcultural perspectives also highlights the fact of whose culture are we talking about? Who has culture and whose culture are we studying? Most often, the researcher feels that that their culture isn't impacting the study in and of itself, that this is an objective scientific investigation. But how we formulate our questions and how we decide which are the most salient theoretical frameworks are all culturally informed. And we need to recognize that aspect of it if we're going to be working with groups different than our own. The effect then of culture of science on how we conduct scientific inquiry into groups different than our own is to recognize that we have a monocultural view of the world and the assumption that science is universal. The impact is of unreflective use of theories developed and validated in European American society and usually with educated populations. The designs of studies based upon these monocultural norms are actually the basis of promoting evidence-based practices and tailoring them to new population groups, which often don't work because the basic premise of these studies, the concepts and the norms, are not the same and don't function in the same relationship in new cultural groups. The use of these tools and methods often have not been validated for cross-cultural equivalence. I was involved with an NIMH project in which they funded 5 different centers for the 5 major ethnic groups to look at the cross-cultural equivalence of the standardized psychological tools. And what they found was it was something like 99.5% of the instruments had never been tested for cross-cultural equivalence, and yet we unquestioningly often apply them to diverse groups without understanding and investigating their cross-cultural equivalence, which then raises the ethical questions regarding the imposition of Eurocentric definitions of health and ways of managing illness without eliciting the context of the issues from the populations of focus's perspective. Cultural equivalence has multiple dimensions. It's often these 6 that are common to the many lists that you'll find if you look up this issue. The first is the content. Is it even relevant? For example, in the mini mental status survey of 10 questions, asking a person what season it is if they're from Puerto Rico or if they live in Puerto Rico. Seasons have different meanings. So is that going to be relevant in their response? How valid is that response to the scale in and of itself? What is the meaning of each item? Is that consistent. In a study I'll describe to you in a bit, I had asked Japanese Americans and Anglo-Americans what their definition of self-esteem was. And both of them felt that that was very important. But the way the Japanese Americans defined self-esteem was humble and no ego. That is not how the Rosenberg scale conceptualizes self-esteem in Western society. So even though they use the same words, they had very different meanings. The mode of administration makes a difference. Is it face-to-face? Is it by mail? Is it over the phone? And for many cultural groups, especially when you're talking about emotional issues, one set of studies demonstrated that only 7% is verbal. 65% is nonverbal. So with the nonverbal administrative modes, you're going to lose the majority of the communication, and how valid then are the responses? The criterion, equivalence, the interpretation must be made in the context of norms of each culture. Conceptually, again, the equal validity of the construct. In a study, in a conference, a World Health Organization conference on pain and quality of life, and that was held in Japan, during the simultaneous translation, they found that they took an inordinate and unexpected amount of time trying to define quality of life into Japanese. Not because they couldn't translate the words, that was simple, but the concept did not exist in the Japanese language. So translation is more than just the words. The conceptual aspects need to be equivalent. And then the metric. What is the salience of the variables and the structural equivalence of the relationship of these variables? And I would venture that the majority of theories have never been tested in this way. So their validity in diverse populations is quite questionable. This is a self-esteem outcomes that I mentioned earlier, and this was done with Anglo females, Japanese females, Anglo males, and Japanese males. This was an ethnographic study that I conducted in which I interviewed people with terminal cancer every month for up to 12 months or as long as they lived. And you'll see that the scale, they scored in 9s and 10s, which is the high end and high self-esteem, but as I indicated, their definitions were quite variant. When I asked them what they defined as a good person, and then asked them to rate themselves according to the scale that they gave me, their distribution for self-esteem was quite different. And you'll see that, look at the yellow for Japanese females and the red for Anglo females, because they were the majority of the group, and you'll see a very opposite distribution. And whether this is socially acceptable responses by the Japanese Americans, because you're not supposed to talk about yourself in positive terms, or whether it was reality, I haven't tested that since. However, you can see that it's still quite variant and will put into question the validity of the Rosenberg findings in and of themselves. In another study on disclosure at end of life, Matsumura and colleagues looked at English-speaking Japanese Americans, Japanese-speaking Japanese Americans. So these are Japanese Americans living in the United States but prefer to speak Japanese, and Japanese living in Japan, and these are elders. The Japanese living in Japan were the reference group, and you can see significant differences between the Japanese Americans living in the United States, which is the point that I'm trying to make with this is that just because the Japanese doesn't mean that they're going to have the same beliefs and values. And both of them differed considerably from Euro-American ideas about end of life and informed decision-making and patient autonomy. They preferred the group decision-making model very much so for the Japanese-speaking Japanese Americans, which varied from the Japanese living in Japan, as well as Japanese-speaking Japanese Americans. So this becomes very complicated, but these are significant variations that need to be accounted for in the sampling. In a landmark set of studies that was done by Rena Pasic and her colleagues that was published in Health Education and Behavior in 2009, they used a mixed method study to test the cross-cultural equivalence of the 5 most common concepts used in behavioral theories for mammography. And they looked at Filipinas and Latinas. They looked at perceived benefit, perceived susceptibility, self-efficacy, intention, and subjective norms. What they found in the deductive survey was that the findings generally supported cross-cultural applicability in 4 of the 5 constructs, however with mixed predictive value across the racial ethnic groups. In the inductive interview, they found that there were social context themes emerged: relational, social capital, and transculturation and transmigration. When they compared the 5 behavioral concepts with the 4 social context themes from the inductive interviews, they found that the 4 context themes influence behavior directly, which circumvented or attenuated the influence of individual beliefs. They were operating also at an unconscious level and were influenced by factors not consistent with an exclusive focus on the individual as these theories postulate. So in conclusion, the authors stated that the applicability of such theories are questionable in diverse cultural groups. So this actually was the first set of studies that demonstrated in a rigorous scientific manner the lack of cross-cultural equivalence in the kinds of theories that are used most often in the United States in public health. So what do we recommend that you do? We've developed a checklist for project development, so any researcher or project manager may then consider walking through this process to specify the steps necessary in conceptualizing and operationalizing culture in research. The first is to ask, is the rationale for the inclusion of culture clearly articulated in the problem statement? If so, has a definition of culture for the study been articulated? And then, are the salient theoretical and cultural domains known to the researcher, to the developers of projects in, say, the community? Are the salient theoretical domains known, but the cultural domains unknown? So, for example, using the health belief model. We know the theoretical domains. Do we know whether the cultural domains of the group that we're interested in working with known, and do they fit that theoretical model of the health belief model? If they are or are not, then we ask the next question, 3B, are salient cultural domains known, but the theoretical domains may be unknown? So we may know enough about the culture to know that they have different beliefs and values or ways of being, but do we have any theories available to us at this point in time that incorporate those variations? The next step would be 4, is there a conceptual framework that specifies how these domains affect the health issue of focus? For example, have the independent variables, moderating, and mediating effects been identified? 5, is there a correspondence between the theoretical and cultural domains? And then 6, are there cross-culturally equivalent existing measures? Most often, the answer to these questions is going to be no. If that's the case, then 1 and 2 are easier because those can be incorporated. From 3 to 6, however, require that different measures be taken. And often then the researcher or the practitioner is going to have to take one or more steps backwards to be able to answer those questions before they can move forward. Because until these questions all come up yes, it would really be a tenuous journey when you know that you aren't perhaps not measuring or incorporating issues that are most salient to the population that you're working with. So in summary, we know that there are hundreds of definitions of culture that exist across disciplines and even within disciplines. Some are explicit, but most are not. So in this presentation, we've delineated the central elements of the current definitions that we feel encompass or encompass all the elements that should be addressed in a definition, and provide guidelines for the researchers to use this conceptual framework to guide their application of culture on the outcomes of focus, to operationalize the methods to measure these effects of culture, and provide a guide to test these strategies for both research and practice. We base this on a scientifically grounded concept of culture. It constitutes a new but a necessary and overlooked approach to research on human behavior. As I started out with the introduction, is that it is fundamental to humans. We cannot exist without it, and yet we have given it only a cursory investigation and incorporation into many of our health promotion strategies. So the new path is promising, but it's long overdue, and I hope that those of you listening will be are on this journey already, or will definitely be able to join us in beginning to test these concepts and constructs. I want to give you the list of the expert panel members who are part of this project. The names in blue are the core staff of this. Annie Fehrenbacher is our project director, and she's here at UCLA as a doctoral student. William Dressler is the University of Alabama. He's a medical anthropologist. Sheba George is at Charles Drew University and is a sociologist, and myself here at UCLA in community health sciences. So with that, I will open it up for questions, and I see that there are some already. So Ashley, are you going to be reading the questions?
Yes, thank you, Dr. Kagawa-Singer. We'll go ahead and move on to the question and answer portion of this webinar. If anyone has a question, please type it in the field at the bottom of the chat window in the bottom left-hand corner of your screen. We have one question. They say, will you be talking about acculturation, especially how to best measure using the California Health Interview Survey data?
That's a powerful question and a really complicated one. I didn't address it in this. We would end up writing an encyclopedia, I think, in this project if we were to address all of these issues. Acculturation is a highly contested concept. Anthropology gave it up in the 60s because they found it was not useful and actually misleading. Because how are we measuring acculturation to what? And what domains of culture? Culture, if you take the definition, is extreme, it's all-encompassing. And so what aspects of culture? Any person acculturates to a new group at varying rates across the domains. So food changes, family structure changes, social support network and definitions of that change, language changes. That's only 4 of probably a panoply of 15 to 20 basic domains of culture. And which ones are you going to measure? The current ones in CHIS are place of birth, length of time in the U.S., and language. If we're doing a health project or clinically, none of those can be changed quickly. You can't change your nativity, that'll never change. Time in the U.S. obviously will make a difference, but it's, what can we do about that in a health promotion project except acknowledge it and address them where they are. And language, it depends on whether people are bilingual or monolingual. And if they're monolingual, then we can't change that quickly either. It will be an indicator, but not necessarily a predictor in the way that it's currently used. So we might be, we would advocate for changing the language and not using the current acculturation scales. Some measure actually ethnic identity, not change in culture to biculturalism. There's actually by John Barry, a Canadian psychologist, who has a different grid of acculturation, assimilation, marginalization, and separation. And those are probably more productive routes to go in identifying where a person is and how to craft a message and the delivery of that message to a new population group. So if you want more, please feel free to contact me. I think they can make that information available to you.
Great.
Ashley?
We have another question. How are we to know when to use this guide or checklist?
That is the first question. Does culture make a difference to the problem you're focusing on? And that will then be question dependent. If you think it does, one, check it out with someone from that community and find out if it is. They may not be able to use the words, the conceptual words that we have, but if they say, well, for example, Korean people don't do this or that, or we think about this or that differently, then it's going to be an issue. And you need to then begin that checklist. Okay.
Thank you.
Just another quick addition on that. If you're working in the area of health disparities and you go through the literature and you find and look at CDC reports, much of it is problematic because all of the major racial ethnic groups, and remember I have problems with those categories as well, but as they're currently put forth and we use them in research as though there's some validity in them, they are within, let me back up even further. Those categories come from the Office of Management and Budget, and they were used to track the progress of society following the Civil Rights Act. They're used in medicine as though there's a biologic factor in them. As race, no. As population groups, yes. But the OMB Directive 15 opening sentence says there is no scientific evidence for these categories. We're using them as social political constructs. So if we are going to use them, we have to use them with that understanding. Now within any of those groups, they're huge aggregations. And we need to disaggregate in order to conduct our studies so that we aren't, again, confounding and conflating and reducing the effect size of any projects we do. Now, having said that then, will it make a difference? And that's where we have to ask the community groups whether, if they've ever experienced any interventions, how was the fit? Probably they're going to say it was okay for the time being, but there was nothing we could do to sustain it because it wasn't normal. It wasn't comfortable. It didn't work in our communities. And that's when you raise the question, what is it then culturally that may be variant that we didn't address or has not been addressed thus far in our interventions?
Lauren, Lorna Kwan has a question. Do you think identifying a person's social network is helpful to identifying culture, especially in looking at patient decision making?
Absolutely, and hi Lorna. The issue of social support actually just came up in a conversation I was having with the core group just the previous hour. And one of the examples from a study that I did was looking at social support for Asian American breast cancer survivors. And we looked at social support networks. And for the Anglo-American women, the average number of members of their inner social support network was 15, and it included the physician. For the Chinese and Japanese American women, the networks were much smaller and neither included the physician. For the Chinese it was 5, for the Japanese it was 3. So I'm not quite sure what aspects of social network are important. Another example was done in Mexico by Bill Dressler, and he showed that for social support related to blood pressure amongst men, that that included in their social support network of compadres were individuals that indicated more social political alliance than emotional support, because they served as an economic resource for them. So culturally, that social network needs to be expanded with different roles for its members. And
it looks like we have another question. They asked, the NIH is promoting biospecimen collection and banking for research to develop new treatments for a whole host of diseases based on racial and ethnic groups and their specific cancer site. How is that productive in advancing cancer research based on the framework you presented?
Hi, Zool. No, thank you for that question. I think it's really problematic. What they will likely have to do is do genetic typing and then go from there. How that will overlap with the racial categories that we're submitting for those studies is questionable. What they're missing, because I don't think we've collected, at least for the CNP programs through the NCI, is the extensive environmental information that we're going to need to know what impacts that genetic profile. And so although I think it's helpful, it's not going to be, we're not going to be able to answer those questions that are likely to be raised by researchers using that data bank unless we go back to those individuals to collect a very different kind of information. And if we know that 95% of diseases are lifestyle and only 5% show genetic predispositions, we may be putting our resources, we could put them in areas that are more productive at this point in time.
Samantha, keep on going, Dr. Kagawa-Singer.
No, I'm just saying that's my personal perspective on that. Sorry, Ashley, go ahead.
No problem. Samantha Karofsky has a question. There seems to be a big focus in health services research on big data and data-only studies. How do we incorporate cultural measures into research where appropriate existing variables are very limited?
Well, that's an important question. I think we definitely need to talk with our colleagues who are developing large surveys. There is obviously power in numbers, but if we don't know who those numbers represent, it becomes problematic in interpreting them because we're going to be making gross statements that may not be that usable for particular population groups. Obviously, that's not the purpose of surveys, but again, how do we utilize that data? And one of the recommendations is to have sub-studies within the larger survey of what we're terming nested studies that are more ethnographic of the population groups, because we don't have those measures yet. And we can't expand the existing variables if we don't have that information. And so we're going to have to create them. And we can do that simultaneously within the large surveys by conducting these smaller, more qualitative ethnographic studies. But thank you for the question.
I think we might wrap up with one more question. Dr. Kagawa-Singer, what specific methods are best to elicit this type of cultural information?
There are many, many techniques to elicit this information. One is to utilize community-based participatory research as an approach, and then use many of the qualitative methods that have been developed in sociology and anthropology to elicit the reality of the groups that we're working with. And there are entire textbooks on qualitative methods, multiple ones. And this is where it would really help those who are more inductively inclined to partner with skilled qualitative inductive researchers who've conducted studies themselves on these issues and can talk about the multiple methods. One of the issues in finding out what the variations are is, in essence, to find out what the distribution might be of differences and what the means and modes are within any population group, so that you can utilize that in your sampling strategies. You can identify new variables. You can look at the prevalence and incidence. We can use all the statistical techniques, but our data is going to be different. We can add to the repertoire of information that we have that will expand both the theoretical models as well as the variables that we can incorporate and make our research much more relevant and valid for the diverse population groups we have here in the United States and obviously globally as well.
Okay, well, it looks like if there are no further questions for this Q&A session, we will wrap up today's webinar. Thank you, Dr. Kagawa-Singer, and thank you everyone for joining us here today. Please join us next time on Wednesday, March 13th, when we continue the conversation with Dr. Ninez Ponce, who will talk about social determinants in health. If you missed any of our previous webinars, please go to the Fielding School of Public Health website at ph.ucla.edu, and they're all archived there. Please allow a few days for this one to post. Thank you, and have a nice day.
Thank you, Ashley.